Okay, now I have with me Dr. Sharat Chandra, and he needs no introduction. And now, what we have here is this lady whose history you just heard. This lady has a complex bifurcation lesion between LAD and a diagonal. Just can you run the film, please? Run the film. Run the film.
Yeah, leave it like that.
There's a very large left main. This lady, as you know, had received a DDDR about in the month of October, and now she has a complex lesion in the proximal LAD, which is a large vessel, and it gives a branch which almost arising at a right angle, and it has a very, very crooked lesion right from the onset, and the combined together with two branches in that diagonal, both of them are significantly large. I think it's a significant territory, and we thought that this vessel should also be addressed. And question arises that we can discuss here, should this be one stent technology or a two stent technology? And if so, two stent technology, then what kind of technique one should use? We have some idea between me and Dr. Sharat Chandra, but would like to listen from the audience. And meanwhile, I'll show you some other views also. Just show the other view.
Leave it like that. Don't go to the next one. Just leave it. No. In fact, you go back. Yeah. You can see this lesion in proximal LAD involving the osteum of diagonal.
So, and then go to PA cranial again. Freeze, please, here. What would one think? I mean, can we have panel's opinion?
I think just looking at the angiogram and the angle at which the diagonal takes off, and keeping in mind that when you have the diagonal, the angle is likely to change. I mean, a two-stent strategy would be preferred because these are really very large side branches. You don't want to lose that to be a sizable impact if the patient does slow down on the diagonal. So a two-stent strategy to begin with first, and I think I would probably say go with the LAD first, then the LAD. Go through that into diagonal and finish up with a good T. That would be the easiest and simplest way of dealing with this problem.
Sorry,
he said a T stenting.
Or T or a tap technique. You know, precisely T technique will be difficult, but some protrusion will take place. So it would be something like a stent the LAD first, and then cross the strut, go to the diagonal, and do a tap technique or a T technique, whatever name you want to give. I think to me it sounds a reasonable strategy. I am agreeable to that. Meanwhile, we also did the IVUS on this patient, and we'll show you the IVUS findings. Just show the IVUS findings, please. We did the IVUS in the LAD, and
leave it here.
At the bottom of the screen, can you switch the angiogram so that you can see it better? Yeah, that's better. Yeah.
You see now here the two side branches, small branches, these are septals, and we are coming back. Is she comfortable?
Yeah, next run. Same thing. Yeah, this is where you are seeing the second diagonal. The one we don't have much of an issue about.
Yeah, can you? And the vessel size here is about roughly 1, 2, 3, little above 3, maybe 3.5.
Yeah, show the next one. This is the part between, yes.
There is a plaque in the proximal LAD. And then we...
Is at the level of diagonal, sir.
It's a level of... Now they are coming more proximally. Keep going.
Next one. Yep.
This is this is within the lesion. A little calcium, but nothing much to drive home about. Keep going.
Okay.
Okay, come
We can discuss
proximally.
the strategy and yeah. Next one.
Next one.
Last one. Yeah. This is the proximal LAD.
Keep coming back. Now we are coming towards the left main. That's the left main. Little plaque, but nothing to worry about. Like if you have it's easily more than 6 millimeter square area, so we are not going to worry about that part. So our strategy would be by the time you come back, you're going to the next lab. I know that. We will be stenting the LAD and then try to cross to the strut of the LAD. And before that, I think we'll balloon dilate both. Do a kissing balloon, put a stent here. You might not want to, but this is such a tight lesion that I think by the time I put the stent in LAD, there is a strong possibility that the lesion in the diagonal may completely close. So we have ventured to dilate that very gently, and we'll see what to do. Okay.
No, just 1 minute. Let's show them what you have done.
Yeah, okay, keep going.
Go to the scene plus. Yeah. Yeah.
So we placed the wire. It was little tricky to place the wire, and this was the whisper wire to start with, and we took another wire, BMW, and so then there were 3 wires here, and then we did an IVUS, which you already saw. It's a gentle balloon dilatation of the side branch.
1 minute.
So as not to lose it. In fact, there was a discussion between me and Sharat that whether we should do a decay crush with using a lower branch. But after dilating a little bit, we saw that there was a little bit plaque shift into the proximal branch, the upper branch. So we dilated the upper branch gently.
Next one.
And then finally did a kissing balloon here. And then
Next.
Then now, having prepared the bed in the LAD, there was no need to have 2 wires in the side branch. So we removed the 1 branch.
Next.
And now
Next.
this was done with the presumptive idea that we might have to do a mini crush.
Yeah, here you
But I
can
think
see
we
the
changed our mind, and that
plaque
there was a
shift.
plaque shift here, which we removed by just a gentle balloon dilatation.
Scene minus. Yeah, you can see
Okay.
here that
So
we
here,
removed the wire from
here we are now,
Yeah.
and this is the situation.
Maybe switch, sir?
Yeah,
Yep.
Right, switch, yes. Switch.
sorry.
Switch right away.
The size of the balloon is initially 2 and then 2.5. Yeah. Okay, they went into there. All right, sir. We'll go ahead.
Okay.
So you have any change in strategy with this?
We'll stand first.
Okay.
Beautiful. Yeah. Okay, so welcome back. Can you hear us? Excellent, thank you. So we're going to show you the right coronary. So you saw the LAD, you saw the optimization of the stent using OCT, and we're going to illustrate now the use of physiology in a right coronary lesion. So, can you see the right coronary angiogram there? Okay. So perhaps we'll show you this. So there's diffuse disease, as you can see, seen plus.
Go for an FFR since it is 0.9. Adenosine.
Okay. So perhaps it might be worth asking the panel what their strategy might be here.
Because it is exactly 0.9. So since being a borderline.
So there's that PDA lesion, there's the lesion just prior to the crux,
Ready with adenosine.
and there's the proximal long right coronary lesion.
medial lesion can be left, that's not very critical, but the other two right corner lesions are quite critical and need to be addressed.
Okay. So we're using physiology here. So what we have used is the IFR technology. So can I so if we go to, can we project the slides that we've got on IFR, please?
Dr. Joe? IFR slides, please. You please continue.
Okay, I'll carry on. Okay, so let's show you what we've done. So if you go scene plus. And plus. Okay, so we're basically trying to work out flow, and if we can get resistance stable, then we can work out flow. Next slide. So pressure in that situation equals flow if we can knock out resistance. Next slide. So we give adenosine usually, and on the bottom here you see how adenosine reduces resistance. Next slide. But this is a graph showing on the bottom how resistance changes over the source of the cardiac cycle. And at the end of diastole, resistance is minimal and low and stable. And that is the wave-free period. Next slide. So in that situation, if we can sample PDPA over that time, we have an index of flow that is not using adenosine. Next slide. So this is, next slide. So this is what the IFR is, which is the PDPA over that wave-free diastolic period. So if we could project the volcano screen now, please. If we can.
Wilson, onto the IFR.
Can we project the volcano screen?
That's your slide. The volcano. Switch to the volcano.
Can we switch back to Cath Lab and switch to the volcano screen? You've got hemodynamics up. It's the other screen. That's it.
Yes.
Okay. So this was us equalizing. This is us equalizing. And this was the initial. And now you see the IFR taken with the wire in the PDA, and where the green is, you can see where is it? It's sampling. Next, please. And so what we've done now is an IFR pullback, okay? So the long segment at the beginning of the graph is the wire being pulled back from the distal PDA into the crux, and then at about 25 millimeters, which is along the x-axis, you see a big jump, and that first jump is the pressure drop caused by the distal lesion. Then we pull back further and it's stable, and then there's another big jump, and that big jump is caused by the proximal lesion. So the panel had it absolutely correct that the physiology of the distal lesion is not restricting blood flow. The major gradient is caused by that distal lesion and the proximal lesion. And what we've done is to use that to target our angioplasty. So scene plus. So we pre-dilated the distal lesion and plus again. And the proximal lesions, scene plus and plus. We've deployed a stent distally, which is a 3.523 Zions plus.
Can you show us the screen? We can't see the.
Shift the screen to the fluoro.
Oh, I'm sorry.
Fluoro. Back to fluoro.
Well, no, actually leave it here because we can show them the IFR.
Okay, now we can see it. Yeah.
Okay. Okay. So this was the distal lesion being treated. Scene plus. And scene plus. And this is the proximal lesion being stented. Plus. 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 Scene plus. Plus. Okay, so this is where we are now, and I'm just for education, we're repeating the IFR now, and we would expect, if the physiology is correct, that this would not need any further treatment. And the IFR threshold should be above 0.9.
Wilson, ready with the balloon.
Okay, so show us
And
this.
then
So if you go now to the IFR, please. If you could just show the IFR screen. Go down one.
So this disconnected.
No, no, I just want to show them the IFR.
Okay.
So can we go to live so
Do you do IFR? Do you do IFR routinely post-procedure, or it's only for demonstration here?
no, I think it's very valuable to do at this post-procedure. Although we understand that this is a theoretical derivation, certainly
3.5
in our experience, we'd either do IFR or FFR post-procedure to make sure that we've optimized the result by physiology. There's good data that residual low FFR does relate to adverse outcome. And sometimes you can be surprised that you can treat what you think is the most severe lesion angiographically, and you repeat the FFR,
OCT ready.
and they're still in the ischemic threshold.
Okay. We are there. See, right.
So we're just post-dilating the distal stent just to make sure we've got it absolutely optimized.
Okay. We have to go quickly. We have only 5 minutes more.
But the IFR at this point, even before optimizing these stents, is already 0.9.
Okay. Shall we go up and dilate again?
Yeah.
A little more up. Okay. Can see.
So it's quite interesting. So we've got an IFR of 0.9 before we've post-dilated,
All right.
and it would be interesting to see how much that changes. And if you stay with us, we'll just try and show that to you.
Okay.
But I think it is important to check the results of stents both by both by physiology, I think, to tell you that you've achieved what you set out to achieve, which is to eradicate ischemia. And the LAD really illustrated to us, I think, how imaging helps us to optimize that result.
Okay. Okay.
Just a question, what do you think is the present status of CT-guided FFR
Okay.
for pre-evaluating this lesion before we take them to the cath lab?
Yeah, so I think that's a very interesting area of good development. As far as I'm aware at the moment, we don't have any hard, robust clinical trials for that.
OCT.
Let's just do an IFR at this point, yeah. But it's certainly an interesting and developing technology, although as you know, the processing taken
Okay. IFR.
to get that data takes quite a long time. So we've done the procedure on the IFR wire, and we're just now using the IFR wire, and we're using that to just see what the result is now. This is really for just showing us whether what the IFR is. Sorry, it's been through quite a lot, this wire. Okay. Okay, so can we go live screen on IFR, please? Ah, beautiful result. Okay.
0.96.
So I don't know if you can see that. Can we project? Okay, can we project that? Okay, so this is the post-procedure IFR,
0.93.
which is 0.93. You can see the green is the diastolic phase, which is that wave-free period. And you can see that this is in the non-ischemic range. So it's above 0.9. So we feel that we've got a very good result for this patient. We've eradicated ischemia, and we don't need to treat the
You go for the OCT.
distal PDA lesion.
Can we
Yeah,
do OCT
yeah.
for this? Okay, fine.
So we've got the OCT catheter already, so we're going to image just to make sure that we don't need to do any more work on this vessel. But what we've shown you is complex angioplasty to an LAD with imaging-guided optimization and physiology-guided intervention to the right coronary, showing a good physiology result and limiting stenting without stenting of the PDA bifurcation.
This FFR wire is very difficult to guide the FFR wire through the OCT.
So we've got a few minutes left. I don't know if the panel or the audience have any questions.
Shall we remove this and put the other wire and do that? Give the other. Illa, edutharu.
Doing an OCT to the right coronary artery just because you opened an OCT
Yes, yes,
to the
yeah.
left side, or would you do that routinely?
So we've got it, because we've got it, we're going to do it. I wouldn't do it routinely. I mean, I think the angiographic appearance, we've put two 3.5 millimeter stents here, which we've post-dilated to high pressure. We've got a good physiology result already. I think it's unlikely we're going to find any major malapposition.
Okay.
But given the importance of giving this lady the optimal result,
Practice how
we're going to do the OCT.
clinical practice, how often do you use FFR?
Very routinely. I mean, yes. IFR and FFR I would use in most of my angioplasty we would do. So Syntax 2 is a trial looking at a physiology-guided strategy for multivessel disease, which has just completed. And that is using IFR with a hybrid strategy, the results of which will be published. So for most of the intervention that we do, we would use some sort of physiology guidance if there is no objective evidence of ischemia prior. as a its superiority is really in workflow patterns and the need to avoid adenosine and the ability not to need to give adenosine. Okay, so we need to switch to the other lab. I'm getting instructions to go.
Okay, we have a stent in the side branch. We changed our strategy. We are going to mini crush or maybe decay crush. So what we have done now is placed a stent in the side branch, and we may this is a stent now?
Yes, that's a stent.
Okay, so just withdraw the stent a little bit, and we will then deploy the stent and crush it. Okay, now I
Can you
need
go for
to
a bigger
make a little bit balloon.
Maggot. That's good, sir.
Okay, right, deploy the stent. ये क्या आ रहा है बीच में? What is this? 4, 5, 6, 7, 8, 9, 10. That's fine.
Would you like to record it?
On the pressure, you be on the pressure.
Yeah.
Are you on the pressure?
Yeah. Okay, this one.
Negative. Now I think we'll remove the balloon and the wire out. Balloon from the stent.
Yeah. The wire also. Both you can come out.
Oh. Yeah. Okay. And now we'll crush the stent now. Tiny shoot.
Yeah. Perfect.
Okay.
Perfect.
Let's crush the stent.
Very minimal.
7. 8, 10, 11, 12, 13, 14, 15 negative. We crushed the stent at 15 atmosphere. Now it's the time to recross
Take a scene.
the side branch stent. Just we'll take a scene now.
I
Okay,
think perfect.
freeze. Okay, let's remove the balloon
Yeah,
out.
wait. This balloon has to come out.
Balloon has to come out. Now I think important is that if you are doing a decay crush, it is not mandatory to cross the distal strut. In fact, it is not desirable to cross the distal strut. In fact, I don't know, Sharat and I feel that the result looks good, but I think we need to complete the procedure for the restenosis benefits. Okay, the wire, please. I need to have a whisper wire or a Fielder XT is fine. Fielder XT.
No, not this. This is gone. Give another. No, you have taken just now, no, one fielder. This
Yeah.
the same one?
It's the same. Fielder XT.
Okay, sorry. Where is the introducer? Yeah.
Helio caudal.
It's okay, leave it. There's no hurry.
Yeah. I can't hear you.
strategy from, say, Stent to, one thing to change the strategy from what is planned because the plan
What's he saying?
Can you speak a little louder?
So now we have crossed the stent.
You know, the reason is our original strategy was to do mini crash. You know, I know the panelists said that you do it later as a provisional stenting, but
Balloon dilatation.
we thought we will stick to our
Give me a
guns.
2 balloon.
And the lesion is a little too complex to leave it at this stage. We thought, in fact, you see the result now. It goes on to support that initial stenting directly is a good idea. Give a 2.
Or even 2.5 is fine. A 2 balloon is fine. 2 balloon. I'll open the strut.
Yeah. This will go, sir. This is in very good shape. Attach the
Unfortunately, audibility is not very good. At least in my my audio system here.
Oh, sorry. Just hold it, hold it.
So far, now what the next step is to dilate the strut of the side branch, which is crushed now, the stent. I've crossed the wire, and I'll open the strut of the side branch stent, and then we'll do a kissing balloon. That will become a decay crush, the first kiss. After that, we'll place a stent in the LAD, and then do a final kissing. I've crossed this. We'll open this now. Okay, open. 4, 5, 6, 8, 10, 12, 14, 15. Negative. Okay, now we'll take it. Sorry.
Yeah.
Again, inject again. Okay, now I'm removing the balloon out. Take a stand size balloon. That is 2.5 in the side branch, that is in the side branch stent, and I'll take a regular balloon, 3 mm balloon in the main branch. After finishing this, I'll put a stent in the LAD.
Yes, I mainly got that.
Okay, 2.5 in the side branch,
Yeah, and you can
3 in the
straight-
left.
Yeah, directly and yeah. So give us 2 balloons, the 2.5, okay, and give the 3.
This is a 2.5 balloon in the side branch.
Okay, this is-
Three balloon, please.
Yeah, one.
Can I give you 3 non-compliant or
Yeah, non-compliant.
50, 350?
Let's see. Yeah.
What's your question?
Now, we have a doubt here. When you position the stent, when you position the stent in the side branch,
Huh?
how much would you protrude into the LED? Will you protrude it a millimeter, couple of millimeter, because you want to crush it? So how
Yeah.
much would you protrude?
Okay, what's the length of protrusion? That's what your question is. Yes, sir. You would.
What is the what's
How
the
much
question?
stent you want it to protrude into the main vessel?
Oh, just about 2 to 3 millimeter.
Yeah. Good enough, sir.
Okay, just a tiny shoot. Okay, here, and I'll bring the side
Yes,
branch.
yes.
This is a side branch balloon, and that will bring it up to do a kissing. Okay.
Okay.
Two together.
Yeah, this is LED.
Yeah, and this is
Yeah.
side branch.
Yes.
I have the side branch.
On pressure.
Yeah. We need to be quick and because last time she developed.
So both
foot
of you
and-
can go to 6.
Yeah, yeah, that's good. That's good. This
You
is,
go to 8.
8, sir.
Side branch 1. Negative, negative. It slipped. Negative. This is another balloon. Okay. Side branch balloon. This is a side branch balloon?
Yeah, this is the one.
Yeah, the side branch.
Yeah.
Lower side.
Can you... Okay.
Yeah, sir, if the one slipping is the LED balloon, sir.
Yeah, I know.
If you just hold it, then that will be good. So, we'll go and the side branch is in your
Yeah.
hand.
Side branch is in my
So
hand.
go first.
4.
4, sir.
You go. 6.
Yeah.
Negative. Okay, now is the time to place a stent in the LED.
Yeah, no problem. We will
So
do it at
during
our own
that
pace,
time-
whatever is possible. So we'll
At
remove
that
the
time-
LED.
Okay, this is the LED balloon.
LED is this blue?
No, no.
Ah,
This is LED.
this is the LED, sir. This one.
Yeah, okay.
Okay.
So the
We'll
LED
put that
balloon is out.
inside, sir.
Yeah. We'll place an LED stand, and I think this balloon should be out also. It is optional to keep this wire there in the side branch now. Actually, one can think of, we can even, okay. Okay, give me an LED stand. What size would you recommend? About, we had sort of 3 to optimize to 3.5. We'll size as per the distal. So, Suresh, what do you think the size of the LED stand as per the IVUS? It's distally 3, proximally it is about 3.75. If I take Onyx, I can
Which
make
is
3 to
the,
3.375 by
this-
optimizing.
This is filtered?
So what's your suggestion? What is he saying?
Okay, you are suggesting a 3 stent, all right? You are suggesting a 3 stent? Okay, okay. 3 and then optimize it to a higher diameter proximally. That's
So you want to, we will Sharat, as we had thought, we'll start from distal to bifurcation,
yeah.
come all the way down, crossing the septal and that other branch, or,
Okay, second
yeah,
diagonal.
so that would be roughly about 24.
Yeah, this is anyway 24 is required. 20,
Onyx 24,
26 fine.
26,
326.
326.
yes.
Just show, just 1 second, bring it here. Just bring it here. What is the highest diameter it will go? Turn it. It will go to 3.4. Okay, if you go to high pressure, Onyx will go to 3.4. That should serve our purpose.
Okay, so now the side branch wire can be
Which one is
removed.
which
Side
one,
branch.
sir? Let's check it once.
Side branch.
Sir, no need to remove, sir. It will give a direction to you.
Why do you want that wire?
It
will
will give
be
a
jailed.
direction in case you have any difficulty in crossing. It is through only one strut of the stent, so it will not be a challenge.
All right. Okay, let's. We need not to. We need not. It has to be. It will be crushed between two stents. So I
All
think
right,
side
if
branch.
you feel comfortable, leave it in. Yeah. All right. All right.
Okay. Side branch balloon.
Remove
Side
this.
LED stand, please.
Yeah. We are taking a Onyx.
What is the question?
Yeah, what he's trying to say is he would like the wire in the side branch to be removed when you are doing it.
Why should I remove?
Why you should remove? Yeah, he wants it to be removed.
I've removed.
Yeah, no, there was thinking behind it. Yeah, it's okay. We are almost done. You want to do?
So you're going to go to that camera, are you? Yeah.
Balloon dilatation.
You have balloon. Yeah,
3 balloon.
Yes, give it.
3 balloon.
Yeah, now you're doing a good job of reshaping it.
New
Should we show the angiogram? Yeah, okay. There is calcium, yeah.
Audible? Hello? Hello? Hello?
Hello?
Hello? Hello? Are we audible? We are from lab 1. Yes, we are going to show you the final OCT run. Yes, go ahead with the final OCT run. Final OCT run of the RCA with the 2 stents. No, we are still with the lab 2.
The strategy that needs to be followed in these kind of cases.
We are still with the lab 2.
Sure, no?
That's straightforward way of taking something like this.
Just show.
Yeah, 1 second, 1 second.
Hello?
Okay. Deploy.
Sir, I think we check it in the
Try again.
lever card.
See again.
It's
Okay.
moving and
That's okay, don't worry. Go ahead.
okay. Yeah, go ahead. You already gone. Okay. Yeah,
7, 8, 9, 10, 11, 12,
yeah.
13, 14, 15, 16. Negative. Okay, are you there still with us? Okay, just show the shot. Friends, it's unfortunately the time is up, but I'm going to do now a final kissing dilatation, and you can see that the result is reasonably good, and this will be for alignment of the stents properly and to prevent the restenosis in the side branch. The final kiss is necessary. My wire is already in the LED. Now what I have to do is to cross the strut, which I think will be very easily, because already the side branch strut is dilated, and I'm so sorry that I have to leave you at this point, but this is the basic principles of a DK cross technique. The crossing of both the side, the final crossing in the side branch and the main branch with the wires is 98% with the DK cross, which is much lower in the midi cross technique. So this is where we are now at this point of time. Let me see if the time permits, then I'll push the wire in. into the side branch.
Then I didn't see you.
All right.